Before setting up a dysphagia clinic, we should know that what is dysphagia. Dysphagia is difficulty in swallowing, means we are not able to swallow solid, liquid, semi-solid, or it takes more time and effort to move the solid liquid from your mouth to your stomach. It is a complex coordinated process and it is basically made up of 3 phases, or we can divide it in 3 phases: the oral, preparatory and transport phase, the pharyngeal and esophageal phase. But why we are talking about the dysphagia? Because the prevalence of dysphagia is up to 20% over 50 years of age in Western countries. It goes to up to 40% over 60 years, up to 80% in over 80 years. The acute stroke patients is having 50% incidence of dysphagia, and among them 50% is silent aspiration. Even in head injury patient and progressive neurological diseases, head neck cancer patient, there are n number of dysphagia patients, or up to 50-60% of these patients are suffering with dysphagia, even in dementia also, pediatric population also, in psychiatric population also. Dysphagia is prevalent everywhere. Why we are so much concerned? Because the main cause of death in these patients are the chest infection and malnutrition, and we have the responsibility to prevent these things and these sufferings. And there must be someone who should tell these patients, or the doctors who are managing these patients, that where the feeding can be done or not, when it is safe to start the feeding, what should be given in the feeds, what utensils you can use for feeding, when should we shift to enteral or parenteral feeds, and when can we shift from parenteral to enteral or oral feeds, when the patient should be intubated or tracheostomized, even when the tracheostomy or Ryle's tube can be removed, and what are the ways to treat these patients by different rehabilitative, compensatory or adaptive methods. There are crores and crores of patients suffering with dysphagia in every country, and handful of dysphagia experts. It is our responsibility to help these patients. Even we all will be suffering with presbyphagia, which is dysphagia or difficulty in swallowing in old ages, in our, say, after 40 years or something. We know our beloved branch is evolving rapidly. We are otolaryngologist, then come the super specialist laryngologist, then the super specialist, the phagologist, and we try to become a phagologist. It's high time to help these patients who are dying or living with impaired quality of life, who are on Ryle's tube, peg or feeding jejunostomy for feeding themselves, and tracheostomized. And we are the people responsible to help them to get out of this misery. So till now we understood that dysphagia or swallowing difficulty is affecting our quality of life with excessive morbidity and mortality in the patient, and early screening and intervention is required for these patients. Our target population is head neck cancer patients, the neurological patients, the ICU patients, neurodegenerative diseases patients, even pediatric dysphagia, and even all of us, or all of the general population people who are suffering with presbyphagia, say after 60 or 70 years of age. It is a multi-specialty team approach to treat these patients, and we as an otolaryngologist are most important, because we know the anatomy, we know the physiology, and we know the instrumentations required. Others, we may take help of radiologists, SLPs, pediatricians, neurologists, dietitians. The purpose of assessment is to feed orally, because it is more physiological, it is life-saving, and it is cheap. How to go ahead? 2 things is required. One is the diagnosis, and another thing is the treatment. Coming to the evaluation of dysphagia, we start from the history, the clinical evaluation, then the instrumental evaluation with video fluoroscopy, and the FEAS, or fiber optic endoscopic assessment of swallowing. Diagnosing, 2 things. One is the screening on the bedside, and one is the diagnosis proper with the instruments. But before trying to assess the swallowing, we should also assess the alertness, the cognition, the airway status, the body posture, and self-assisted feeding potential of the patient, because we can't assess the dysphagia or we can't feed the patient if the patient is intubated, if the patient is comatose. So coming to the basic clinical examination, the BP, pulse, pallor, everything, the malnutrition assessment, the relevant systemic examination, the important cranial nerves which are involved in feeding, like 5th, 7th, 9th, 10th and 12th. Now coming to the bedside screening, it is done for the patient who are not fit to transfer. And the likelihood of this bedside screening examination, the sensitivity is up to 90% and specificity is 66%. The first part is the preliminary assessment, in which the dry swallowing, or we ask the patient to swallow his own sputum, and we see the vigilance, the voluntary cough, throat clearing, saliva swelling and laryngeal elevation. Then we start with the different trials of swallow, the liquids. Some start with thin water, the thickened milk, the semi-solids and solids. There are n number of protocols, but you must make your own protocol and follow in every patient so that you can compare your own results. For this screening examination, the patient should be seated in upright 60 degree and should perceive the testers or our face, spoon and texture in front of him. We start with the liquid from 3 ml, then 5, 10, 20 ml and last 50 ml with the cup feeding. Then the semi-solids and the solids, small pieces of bread or cookies. And we observe from loss from mouth, spontaneous coughing, any spontaneous throat clearing, any post-swallow wet voice, any nasal regurgitation, oral transit, laryngeal elevation, and we should abort the investigation or the screening if the patient starts coughing within 1 minute of feeding. He starts drooling and the voice changes. Pulse oximetry. According to latest guide, pulse oximetry can't help in detecting aspiration. Coming to the definitive diagnosis of swelling, two things. One is the FEES, fiber optic endoscopic evaluation of swelling, and the video fluoroscopic swelling study. Sometimes we use manometry for upper esophageal sphincter dysfunction and dysmotalities. Coming to the FEES, it evaluates pharyngeal phase. We have told that, I'm telling that the 3 phases are there, the oral, pharyngeal and esophageal phase. Pharyngeal phase is mainly evaluated by the FEES. In the FEES, patient is in upright or semi-reclinable position, examiner is in front, and we use nasopharyngoscope. No anesthesia is required. It has 2 parts. One is the dry swallow and the second is the swelling assessment with food. In the dry swallow, we see any saliva in the nasopharynx, the velopharyngeal closure, the secretions, base of tongue and hypopharyngeal laryngeal movement, secretions, pharyngeal movement, laryngeal function, sensory test, and FEES is the examination we can do even in uncooperative ICU patients, as we can see the secretions and saliva and its management or whether aspiration is going on or not in these patients. Then the second part is the swelling assessment with food. Coloring agent is used with the normal foods, and we see for the movements like velopharyngeal closure, tongue base, pharyngeal contraction, laryngeal involution, and the whiteout. Whiteout is very important because it indicates that pharyngeal constrictor muscles are functional. We look for any spillage also. For the oral phase, sometimes we do fiber optic laryngoscope angulation and go in the oral cavity. Sometimes we follow the bolus in the esophagus. This procedure is known as goose, the guided observation of swelling in esophagus. Complications of FEES. It is absolutely safe procedure. Disadvantages. Only pharyngeal phase is involved. We can assess. Sometimes the lesion is simultaneously present in pharynx and esophagus. We will miss the esophagus phase. Sometimes a lesion is there in esophagus, but the symptoms patient is, they have symptoms in pharynx only. But the main pathology in the esophagus means referred symptoms. We may miss these cases. Due to cortical inhibition, if any problem is there in the esophagus, it may cause dysmotility in the pharyngeal or even the oral phase. In those cases, we may think that there is pharyngeal dysmotility, but the problem is in esophagus. Due to the phenomenon of whiteout, in the pharyngeal phase, it is 1 second. The whiteout is 0.5 second. Only 0.5 second is left for you to visualize what is happening in the pharynx. We don't know exact amount or percentage of bolus being aspirated. In pediatric population, due to higher larynx, the visualization of laryngeal structures during fees is quite difficult. The pediatric population or the neonates are obligate nasal breathers. You are giving feed to them, so only nose is left for respiration. Among one nostril you are introducing this endoscope, so only one nostril left for them to respire. And in these cases, the normal suck-swallow breathing pattern among the neonates is disturbed, and there will be false impression that the child is having worse dysphagia. In the child, there is continuous suck-swallow breathe cycle with whiteout during swelling. It is not cue-based that in adult we ask the patient, okay, you swallow and we see. The child is swelling continuously. The pharyngeal phase in a pediatric population is 0.73 seconds. Among that, 50% is the whiteout. So in 0.3 seconds, and that is also being continuously closing and opening, it is very hard to know that what is exactly happening in these patients. So fees interpretation is very difficult in pediatric population. Of course, compliances will be there. Coming to the video fluoroscopic swelling study. Actually, my next lecture, continuous lecture in VFSS, so a bit elaborately I will be talking about this in my next lecture. Coming to the endoscopy versus video fluoroscopy, or say FEES versus video fluoroscopy. The FEES has advantages, of course, because it visualizes the bolus, surface anatomy or mucosal anatomy is visualized, the sensation we can visualize, the secretions we can visualize. In coming to the video fluoroscopic swelling study, the advantages is that all phases are tested. The swelling response time, pharyngeal transit time, esophageal transit time, I will be telling about these in my next lecture. The basic difference between FEES and VFSS, one is the pharyngeal phase and second is the all phases are required. FEES is very important for neurological patient in the ICU. We can examine bedside, we can examine repeatedly because there is no radiation involved. We can see the secretions and we can know the sensation of the larynx. Other than these things, in my opinion, video fluoroscopy is always better because we are examining from the oral cavity to the G junction at one go. What is happening in each phase. We can call ourselves a neurophagoologist, and setting up dysphagia clinic is not a costly or complicated venture. We can easily incorporate in our routine setup. FEES we can do regularly, we can do in our clinic very easily. In the video fluoroscopy, I will be talking about in the next lecture that how we can set up a video fluoroscopic dysphagia center in our clinic only. We can have great impact on the patient for treating these crores and crores of dysphagia patients.